have a question for Dr. Rakesh, sir.
Yes.
Sir, in our end-stage renal disease patients, how can you compare the use of two novel second-generation basal insulin available, IDEC and Glargine 300?
Yeah, so that's a challenging situation. Renal failure is a challenging situation where very often we find that there is a reduction in the gluconeogenesis, and this can lead to lower fasting glucose levels. So in those patients, I think the basal insulins are not required in those patients, but there is a equally large number of people with renal failure who have an increase in the glucose levels, fasting glucose levels. That is probably because of the fact that they have accumulation of various metabolites and various inflammatory mediators which are causing the insulin resistance to go up significantly. And there, I think there is a need for the basal insulin analogs. And between the two of them, I don't see much of a difference. I mean, although if you look at studies from those which are sponsored by Novo Nordisk, will show a better efficacy with say degludec, and the other way around will also be seen. But I think both of them are equally good in terms of reducing the nocturnal hypoglycemia, and in such a situation where they're required, where the nocturnal hypoglycemia is a major problem, even though one of the use of either of them is going to be very helpful.
I purposefully asked this question because there is a mechanism of action of IDEC. They binds with the albumin, and there is persistent hypoalbuminemia in end-stage renal disease. And there is also no window period option of plus minus 2 hours, which is more available in Glargine 300. So I don't want to say anything, but it's your comment. How you take in between two is a better? I don't want to compare, but it's your opinion.
Yeah, as you said, theoretically there is a benefit of using U300 Glargine in that scenario as compared to using degludec, because the hypoalbuminemia is there if we are giving importance to that. But again, I doubt if there's. I mean, we don't have a good data to compare these two in that scenario. Although there is data to compare in other scenarios, we don't have studies which have looked at patients with CKD and comparison to insulins. Dr. Boraskar sir may add to this.
Yeah. Now, you see, you try to understand. Now, all these new insulins will come, and they will be available, a finer version of, various molecular biological improvement. As you realize that probably there is a lot of money being poured by these companies for developing new molecules. But we have to see the utility in a larger perspective in our country. Try to understand the technology is very important, but how you take it at home, how you take it to patient's house is an art of medicine. How you convince a person that, look here, this is the problem and this is the way you have to deal with. So this is going to be a challenge, and the healthcare professionals must have adequate skills of having, first of all, develop a faith in themselves, then their faith in their tools, and the patients must have faith in these doctors, so that, look here, this doctor is trying to tell us something which is a little different than all this time, but it is in my benefit. And the way you can talk, your personality, your conviction, your own hard work will take the message as well as therapy to the doorstep of the patient. So this is my mantra for you, and I am very happy to have shared my viewpoints with all of you. Was such learned, lot of audience, and I would like to even ask the permission of the chair to allow me to leave, because already very late, and it's a way past my prandial time. So thank you again once for giving me an opportunity.
Thank you.
Thank you very much, Boraskar sir, for an excellent session on insulin.